Well, it's that time of the week again, and once upon a time, there are two guys that went inside EMS. One guy was he was mean. He was kind of mean. He's from the South. He actually migrated to the North. The other guy is very humble, very modest, a very good-looking guy with a great sense of humor. One is Chris Cebollero, one is Kelly Grayson. You can figure out who is who, which is which. But have we got a great show for you today, KG? What's going on up there in the Empire State? Are you a Jets fan yet?
No, but I am pretty happy for them beating the Bills. Pretty darn awesome. Looks like they're scratching and clawing and doing a heck of a lot better than that other New York team that seems like it's circling the drain. So.
No. There's no bad mouthing New York sports teams. It makes no difference who you root for. Now this is just an education. You support all New York sports teams, even the Bills. Yeah.
Yankees fans,
Everything. You got to talk about the Islanders. You got to talk about the Rangers. You may even squeeze in there the New Jersey Devils, but that's a whole other show. But we're excited for everyone to be here with us today. If you're watching us on video, thanks for joining us. But you can see we've got a couple guests. My friend, Chief Dave Lewis, he's the Assistant Chief of EMS at the St. Charles County Ambulance District, one of the premier EMS agencies in the state of Missouri. And when I was at Christian Hospital, I was always kind of chasing them for best practice. And, Kelly Gaines, he is the Director of Community Relations. And they got a program out there, I got to tell you what, that if you're in the community space, really it has to be duplicated because this program has been running for a long time. I remember when it started, and just more and more, we're hearing about the great things that are coming out of it. It's called the St. Charles County Mobile Integrated Healthcare Network for SUD, OUD, and behavioral health. And Chief, I think the first question goes to you, right? So when you think about this from the standpoint of substance abuse and behavioral health, how did this come about as part of your community paramedicine vision?
Oh, first and foremost, this was a passion project to save lives. We were, just like every other EMS and fire department across the country, 5-6 years ago, we were inundated with overdoses. It used to be that you would run more hypoglycemic cases than you would overdose cases. And now, fast forward 20 years later, that trend is different. You run a whole lot more overdose cases now than you do patients who are hypoglycemic. So with that, we've seen those trends going up, and one of our rock star paramedics came to us and said, look, I'm seeing this trend in the field, and we were seeing it in administration, and we put our heads together and said, we've got to do something. We looked across the nation to find best practices, and one of the practices that we found came out of Coleraine Township, Ohio, where they were sending a paramedic and a social worker and a law enforcement officer on overdoses with the intent to try and get these patients into treatment. And we said, well, there's our answer right there. We need to be able to touch these patients and help get them to treatment, because without it, we're just, rinse and repeat over and over again, running these same overdose patients.
Right.
Well, that started back in 2017, and we quickly found out that those patients didn't embrace that model with law enforcement tagging along. They were less than open, less than honest with us. So we dropped that portion of it. And then we quickly found that the social workers didn't have the capacity to respond with us on all these overdose calls. So it necessitated our paramedics become specially trained to be able to have those hard and tough conversations.
Sure.
And getting those patients into treatment and linking those with those providers. So that particular program started out from those humble beginnings back in 2017, and it's grown ever since.
Yeah, and I got to tell you, like you said, I was across the river at Christian Hospital in North St. Louis County, and I said this from the very beginning when I arrived in 2010. I have never seen the amount of overdose in my career as I've seen in this area, right? And it just went ahead and went across the river. It knows no bounds. But Kelly, when you think about this from the standpoint of community paramedicine and how people are doing this work, I think we've got a great story here.
Yeah. Kyle, Chris and I have covered this before. You can tell that Chris has me on the brain since he called you Kelly Gaines.
Did he? I'm sorry, Kyle. I'm sorry.
It's all right.
I don't want to mix. I don't want to mix you guys up. That's for sure.
Normally, my shirt says K Gaines, and I normally get a lot of Kevin whenever I'm out in the community. So it's okay. It's a new K name to throw in the mix.
All of us ruggedly handsome, stellar paramedics tend to look alike and get mistaken for one another. Yeah, Chris and I had talked about your program. I forget the name of the paramedic who came to y'all. What was her name?
Lisa Cassidy.
Yeah, and we lauded the program back then. I was wondering what was in your role as the public information officer. Have you had any pushback or have you had buy-in from your team in doing this? One of the things I've noticed in talking about risk reduction and safe injection sites and that sort of thing is that still a whole lot of paramedics tend to look at opiate abusers as something less, and they think we're enabling. Have you run into that?
Absolutely. On the onset, I think every organization faced a little bit of that, or a higher degree of that. But one of the things that made the substance use recovery response team a success in those early infancy years was the fact that before we rolled it out, Lisa and her team worked with some of our community mental health partners and brought all of our team members in for face-to-face training on addiction. And I really think that made the big difference because Lisa got a lot of feedback after those initial trainings. People that just flat out said, I had no idea, because a lot of these folks in their paramedic program, some went through 5 years ago, some went through 10 years ago, some upwards of 20 years ago, and said that the amount of mental health training they had gotten in their programs was really rather limited, and that the training that we put all of our people through was truly eye-opening for them to really delve down into the science of addiction.
Yeah, that's very interesting. And just so you know, Kelly, I may have got Kyle's name wrong, calling him Kelly, but you got his title wrong. He's the director of community relations, not the PIO. But yeah, so I mean, we're one for one now. So let's see what I can screw up with you today, Chief. So when you think about, you guys have been doing this program, as Kelly said, we talked about it when it first happened, and it was all over the news, and we wanted to be able to watch it closely. And now really you're setting the standards for others to follow. So if you think about this, do you have any numbers you can share with us or the successes that you've had? I mean, because now the program's 6 or so years old. And just the amount of work that you've been doing, again, really sets the standards for others to say, we gotta duplicate this program in our system.
Sure. So post-COVID, we would see around half the patients that we encounter agree to be enrolled in the program, and then half of those patients would actually end up getting to sit in front of a treatment counselor. So about 1 in 4 patients that we would come across, we would have success with. That was pre-COVID. After COVID, those numbers have dwindled, and it's become more challenging to get patients to agree to go to treatment and then get them in front of those counselors. It's been difficult. We've actually seen our numbers decline when it comes to calls for overdoses in the field. One of the anecdotal factors that we attribute that to is the readily available Narcan in the community now. And we're one of the distribution sites for public Narcan, and we encourage it. But one of the tenets that come with that is we urge folks to call 911 too, because those patients are going to need medical support and care, not only recovering from their overdose, but thereafter. And our fear is that's the part that's missing when the public uses Narcan and they don't call 911, the patient wakes up and no one hears from them again. So we want to get that word out there that even though that public Narcan is available, you need to engage 911 and get those paramedics going. Otherwise, the opportunity for linking that patient to treatment in the moment is slim.
Yeah, and it's really just I didn't mean to cut you off, Kyle, but it's really just the team approach to it. We're thinking that a box is going to make a difference. It's not just the box, right? It's the support structure. But I didn't mean to cut you off, Kyle. What were you going to say?
Oh, I'm sorry. And I was just going to piggyback onto what Dave said. And honestly, I think there is still a great degree of, even if it's a family unit, if it's a spouse, if it's another loved one, there's still stigma. There's still that embarrassment factor that this is something that someone, a loved one, a family member is struggling with. And I think that's why that 911 call is not being made. They feel like, okay, I administered the Narcan, I did what I needed to do. They've come around. We'll try and work through this on our own. Try and work through this together. We don't want our community to know that we're struggling, and that's what we have to try and get past as a society, because this is something that's incredibly difficult to go at alone. I think anybody listening to this podcast is well aware of that fact and has seen those folks that have those terrible withdrawal symptoms, that are struggling, that have the GI symptoms, chills and sweating and everything else. And that's why we say, please activate 911. Let us come. Let us try and provide that support system right at the time of that after successful revival.
It's kind of a double-edged sword. You would like people to reach out to you when they utilize the Narcan you've distributed. Yet they're not. But I suppose you have to be happy with at least some reduction in calls. Any progress is good progress. I was wondering, Kyle, is how your mental health and health partners in the hospitals and everything have received the program. Are they majorly in favor of it? Are they happy with the results?
Our partners that we've been working with from the onset of this, Preferred Family Health, Compass, and a variety of others, both in our region and outside our region, have just been tremendous advocates of this program. They have talked about it in their circles, just like we've talked about it in our EMS circles. A lot of what we do here at the ambulance district, not just in the realm of substance use disorder treatment, but a lot of our programs center around collaboration and partnership. It's finding those key partners within your community to work with. And when we come together on things, really good things result. It's been our experience.
It helps when you come off mute. But one of the things that you also get is you find that a lot of these community partners have resources that aren't being used, right? And that's one of the big components of community paramedicine, is connecting with those community partners, those community programs that we're able to connect our members with, our patients with. But, Chief, one of the things that you talked about was, you try to get people enrolled in the program. And I guess I should have asked this question from the very beginning, maybe just to outline, what does this program entail? I mean, how long is it, or how do you guys go about it? So we're telling people that they need to duplicate what you're doing, but we really didn't get to the crux of what the program's about.
So the way our current program is structured is a patient overdoses, they call 911, our 911 paramedics respond, they revive them, and it's there at the scene in that moment that they have the conversation with them that there's opportunities out there to get into treatment. And we're happy to be that helping hand and that link to get those patients into the seats at those treatment centers, into those intake spots, and talking with those counselors. We know all the different resources that are in the area, what they specialize in, what their different niches are, and we can help those patients make those decisions. We found that our success was 1 in 4, and it's dwindled since COVID now. But the biggest gap that we found is the delay in us talking to them on the scene and actually getting them into that treatment center. We lose so many patients because once we give them Narcan, we make them sick. We throw them into precipitated withdrawal. And that's just about every service in the country that comes across an overdose patient. If that patient is chronically using, The minute you give them Narcan, you're going to throw them into precipitated withdrawal, and they're going to be getting sicker and sicker and sicker until they use again. So the number one thing that's on their mind at that particular point in time is, please get out of my house. I need to get well. It's not that I need to get high again. It's that I need to get well. And that's where we've lost the majority of our folks. And we've seen it time and time again, year over year. Even back in 2017, we said, man, if we could just duplicate what's going on in the treatment centers right here, we could save more lives. And back then, those were inpatient spots. That was the gold standard back in 2017, was to get patients into a treatment center with an inpatient bed. In the next 18 months, the model changed to where it was no longer an inpatient bed that was the gold standard, but it was medication-assisted treatment in an outpatient setting that you could stabilize patients, get them off of the illicit drug, get them in more of a stable lifestyle to where they could attend counseling, they could become functioning, they could become stable, and start seeing the different benefits of staying away from illicit drugs. And those were the models that started to change even more lives and have even greater success. And it was the advent of medication first assisted treatment that got that going. And once the outpatient opportunities opened up, we had even more spots that we could send our patients to for treatment. But it wasn't enough because it didn't fulfill that gap from the time we gave them Narcan, made them sick, till the time they sought to be well. We knew at the time medication-assisted treatment was working. We seen it after the fact, but we were powerless to do anything about it in the moment because of the laws and regulations, some of which dated back to the early 1900s with the Harrison Act, that prevented those kinds of things from happening out in the field by paramedics. Fast forward to 2019, 2020 with the advent of COVID and the pandemic, a lot of flexibilities came out of the pandemic with CMS and some of the federal laws and regulations that allowed for telemedicine and medication to be prescribed and administered via telemedicine, where the requirement was that the patient had to present in person first. Well, when you start having those kinds of flexibilities, those were the opportunities that we said we could do even better. We could close the gaps in these spaces if given the opportunity. Fix the patient's issue in the moment, stabilize them with medication first, and get them across that hump, whether it's an overnight or whether it's a 3-day holiday weekend, or whether it's a week long to open up a bed or an outpatient spot in a treatment center. That was what we were targeting, and that's what we've been trying to do since 2017. And with the advent of the COVID flexibilities, we've seen that as our opportunity to really make an impact in the space. It was not only us seeing that opportunity, but other EMS agencies across the country seen it also. Pioneers like California, like New Jersey, they started working in that space before we did here in Missouri and showed great success. And those are the pioneers that we're following now.
Dave, you mentioned the Narcan administration causing precipitated withdrawal, and I think a lot of our listeners, a lot of EMS people in general, don't appreciate the fact that opioid addicts, once they're addicted, they're not taking the drug to get high anymore. They're taking it merely to not get sick and
not feel the pain.
That's right, not feel the pain. So I'll throw this one to Kyle. Now you got this grant, this $1.5 million grant that's going to allow you to administer buprenorphine as medication-assisted addiction treatment. Tell us how that works.
I'm actually going to kick that one over to Dave because that is much more his area of expertise in this arena than mine. Mine's more on the public education side of things.
Okay.
So,
And Chief, before you do that, I think Kelly's question is poignant. But one of the things that I think maybe you can throw on top of that is, what made you apply for this grant? First off, I mean, we're really trying to look for ways to fund our programs. And is it hard to do it? There's a lot of people that probably would apply, but if you can kind of hit those 2 points, I think that'd be awesome.
Sure. For us in the moment, we knew that we were losing patients because we couldn't stabilize them on the scene. The minute we left, they were going to go seek to get well. We needed to have a way to have a paramedic be able to respond and provide medication assisted treatment in the field, but not just medication assisted treatment. One of the things that we've learned, especially with our substance use recovery and response team, that was Lisa's team that led this charge since 2017 with connecting patients to treatment. One of the things that we've learned using that rockstar group of folks was the different needs of that particular patient population. What we've also learned is through our mobile integrated healthcare provision of community paramedicine, through our other rockstar team with our MIH team members of Kimberlyn Tyne and Sherry Hercules, we've delivered mobile integrated healthcare community paramedicine to patients who were high utilizers, who were had high risk of readmission or risk of returning to the hospital after discharge because of confounding medical issues. So we've been working in that space, in the community paramedicine space, not just with overdose patients, but also with chronic disease patients, getting them stabilized, looking at social determinants of health, looking at care plan compliance, looking at medication compliance. So when you look at the patient, you've got to look at the whole patient and the services that they need in order to be successful. You can't just look at one part of it. And historically, we've all been siloed and we've looked at one part of it. In order for this particular program to be successful going forward, we needed to be able to offer this service 24/7 and have a specialized paramedic be able to be on call as a single resource that's out there available 24/7. And that's what the grant's going to help us do. But it's not going to allow them to just administer medication assisted treatment. It's going to enable us to provide those assessments, to look at social determinants of health, to look at what barriers are going to be in place that will be in place that we can remove so that this patient can be successful in their pathway to care. That's the type of service that's going to make these patients be successful. And it's multifaceted. So we combined our specialty overdose team with our mobile integrated health team, and we're putting their brains and their education and their resources together to focus on this particular population, but not just when it comes to substance use and overdoses, but with behavioral health and with high utilizers. So we're coming at it from a multifaceted effort. And with that, we'll save more lives.
Okay. I want to punt it back over to Kyle. So Kyle, and this is in your court. You can hit this ball. What are your strategies now that you have this additional capability of administering the buprenorphine? How are you getting the message out to those users who may have been reluctant to call you in the past? What's your approach to that?
Well, reaching utilizers is typically the largest majority of them are going to still come in via 911. However, we pair that with a pretty substantial, communication effort here within our community, using our broadcast, our trade organizations like yourselves, magazines, print, things of that nature. But it's also grassroots marketing. It's getting in front of groups in our community, which is something that we've done via the substance use recovery response team basically since its inception. It really, even before our forays into the realm of treatment referral, we were in the prevention education game. Those discussions with youth audiences talking about, not even once when it comes to heroin, fentanyl, things of that nature. And that conversation has evolved over the years, because when we started this, it was all about, we've still got shirts that say stop heroin on the back of them. And now it's no longer heroin that we're talking about. Then it evolved to heroin laced with fentanyl. Then it was, we were just straight up, now if people are buying fentanyl, actively seeking fentanyl out. Now we've got Xanax and other designer drugs that are being laced with fentanyl. So the conversation continues to evolve that we have with our youth audiences and tackling that prevention angle. We still do some of that prevention discussion with older groups as well, chambers of commerce, Rotary clubs, those your traditional types of audiences that you can get in front of. But we still largely focus the preventative efforts on our youth population and trying to help them understand just how dangerous a game this really is. And we do that in collaboration. Again, I speak a lot. That's probably the word I use most frequently around here, our collaboration and partnership. But it really does, it does work. And we do that with our school districts. We do it with the DEA, based out of St. Louis. We do it with our local law. We do it with our fire department. And all of us come together for things like our Teen Drug Summit, which is something that's put on, by our Crush Coalition, Community Resources United to Stop Heroin. That group formed, again, as the name suggests, back whenever heroin was a big conversation point that we were having. And that group puts on that countywide Teen Drug Summit that sees 500 or so students from 6th through 8th grade coming in, and then they carry that water back to their classmates each year. We also work with a couple of school districts individually on, we call them our mini Teen Drug Summits, and those are at junior high buildings throughout the community. Not every school district opts to do that, but several of them do. We are always willing to take on more partners. And is it a lot of work? Of course it is, to get into all of those buildings and deliver that message face to face. But there's some conversations that are tough conversations that should be had face to face and not via video, not via something that we just trot out the same curriculum year after year. There's something about hearing it from the paramedics who are seeing the terrible aftermath of this day after day.
Yeah, that's very cool. And Chief, knowing you for as many years as I have, you're very you share a lot of your stuff. You're very open when people are coming to your place to kind of check out. I mean, you've got a cathedral over there for an EMS department now. I mean, it's a beautiful building. You were kind of the one of the architects of making that happen, and you're very good at sharing stuff. So if people want to learn more about this program and maybe try to have you guys be a mentor as New Jersey's and so on are doing for you, I mean, is there a way that they can get in touch, or what's the best way they can learn more about this program?
Chris, the best way is to email either myself or Kyle directly, and we'll certainly reach back out. We're an open book when it comes to our programs and processes, because it's one thing to be able to save lives in our backyard, but if we can save lives across the state and across the nation, we're all doing what we've been called to do.
Yeah.
This grant for us has had, there's 4 different legs to it. The first leg is actually providing care in the field to these patients. The second leg is harm reduction. And the third and fourth leg is education, both public and to the medical professionals. So one of the things that we wanted to focus on through the grant is education of first responders and all medical professionals. We've come a long way, but we've got a ways to travel when it comes to educating our first responders and our medical professionals on the science of addiction. That is, chemical changes in the brain pathways that cause predictable responses that are not controlled by the patient anymore, but become physiological demands their body and brain will work to get outside of what might be considered the reasonable means. By any other name and definition, this is a chronic disease, one where patients can't get well on their own and need professional medical care, treatment, and medication to overcome the degradation of their normal physiological pathways and get them stabilized and in a place where they can get back on track to start to manage themselves, their lives, and their care again. That's what we seek to do.
Very cool, man.
Chief, you've highlighted what should be a model program for the EMS system around the country, and I applaud you guys for being proactive in caring for your community rather than our traditional reactive after the fact. You guys, listeners, you've heard what we think. You've heard what we brought to you about this program. We'd like to hear what you think. What kind of steps are you taking in your communities to combat the scourge of opiate and substance abuse? We'd love to hear your thoughts at the show at ems1.com. For myself, co-host Chris Cebollero, Chief David Lewis, and my fellow member of the initial KG Club, Kyle Gaines. We'll catch you guys next week.